My name is Kristen Kreutzberg, and the issue I chose to study is proper care when tending to a surviving family of a child who died from pediatric cancer. I am an undergrad student at James Madison University, graduating spring 2021 with a Bachelor of Arts degree in psychology, a minor in family studies, and the hopes of one day becoming a therapist for kids with cancer and other terminal illnesses. Love Your Melon is an apparel brand dedicated to giving a hat to every child battling cancer, as well as 50% of their profits to nonprofit organizations around the world that support the fight against pediatric cancer. Throughout my college career, I was a part of our campus crew and got to visit children's hospitals and deliver beanies to kids fighting against pediatric cancer. From this experience, I got to meet many amazing children who were amid fighting this deadly disease, as well as some of their families. Every day, 43 children are diagnosed with cancer. 12% of children diagnosed with cancer do not survive. The average age of children diagnosed with cancer is 6 years old, and more than 40,000 children undergo treatment each year. Children's cancer affects all ethnic, gender, and socioeconomic groups. Do you know anyone who's been affected by pediatric cancer, or do you know someone who's lost a child from pediatric cancer? Children outliving their parents, or parents losing a child at a young age by any means, is unnatural and something that no one should have to experience. When a child dies, the family is stuck with the unfortunate position of trying to make sense of nonsense, leaving them in a cycle of ruminating, grieving, and coping, something that is harder than anyone should ever have to. The question, will the family ever actually recover, is one that has been studied previously, and while the blatant and obvious answer assumed is probably not, said families must still figure out how to at least carry on. The underlying assumption of many studies of bereavement holds that although depression can be regarded as an expected grief response, with time, the bereaved person should return to normal and thus no longer be depressed. One study examines 40 mothers and 26 fathers' states of depressions 2 and 7 years following the death of their child from cancer. The findings showed that parental depression after the death of a child from pediatric cancer does not change significantly between the 2nd and 7th years post the child's death. Time did not change the emotional state of parents, and although most parents were living functionally and what they considered to be meaningful lives, many still felt the presence of an empty space in their lives even after 7 years. This suggests that bereaved parents do not fully recover in the sense of returning to who they were before the loss of their child. Instead, they appear to change as they integrate the loss into their lives. Using this evidence, my application will aim to make this integration and process of adapting to the loss rather than recovering from it as considerate, supportive, and constructive as possible. Everyone experiences grief in their own unique ways, so it is difficult to establish a universal method to cope. A study with parents whose child died from cancer revealed that parents who were best adjusted after the loss were those who had a consistent philosophy of life during the course of the child's illness, had a reliable support system or support person, and who provided their child with the information and emotional support he or she needed during the course of the illness. Using the wet blanket theory in accordance with the basic structure of the Pediatric Psychosocial Preventative Health Model, I will establish a threefold application program that focuses on families attaining healthy measures of these attributes while also keeping in mind the vast account of variables survivors face, including their relationship to kin, gender, culture, emotional openness, and each family's uniqueness and individual wants and needs. Using the Pediatric Psychosocial Preventative Health Model to analyze and aid grieving families of a child suffering from pediatric cancer under the wet blanket theory, I attempt to create an application program addressing the victim family at times that I will call palliative intervention, grief intervention, and postvention. The Pediatric Psychosocial Preventative Health Model is a conceptual model to guide screening and services for all family of children entering the pediatric healthcare system, but with higher levels of care to those families most at risk. The use of the term universal is retained for the largest group of families, but targeted is used to indicate those families at higher risk and in need of services and clinical treatment to highlight those families at higher risk. It has been said how losing a child to cancer can metaphorically be explained as being covered in a wet and dark blanket. The blanket was already present and covered the parents when the child was in its palliative phase. To see the child suffer was emotionally arduous, but facing the child's imminent death could be even more difficult. Despite the blanket, it seemed important to the participants to find the strength to talk to the child about the child's forthcoming death. During this time, I will implement the first part of my application, which will be the palliative care intervention. Palliative care focuses on comfort and quality of life, and unlike other forms of childhood death, such as perinatal death, accidental death, and suicide, which are all very sudden and unexpected, terminal illnesses most of the time give warning prior to the death, and the family still gets some time left and the chance to say their goodbyes. From this point, the palliative care intervention phase will be a 3-week asynchronous program given at the time terminal diagnosis is made. This program will focus on anticipatory grief and the 5 stages of grief leading up to acceptance of the reality, followed by exercises and tools that will aid immediate family and help them cherish what's left of their child's life. The palliative care intervention program will be led by a mental health professional, and it will teach families how to have an open and effective means of communication with their ill child about the reality of the situation. Additionally, as part of the program, the family, mainly parents and siblings, will create a therapeutic keepsake, either virtually or physically, including affirmations, journal or blog entries, photographs of their child and their family, and moments from the child life to help them start accepting the situation for what it is and giving them an outlet to express their emotions in a productive and meaningful way as they savor their final moments with the child and prepare envisioning a different life once the child has passed. The wet blanket theory continues to say, when death appeared, the emotional and cognitive process of moving from a living child to that of a deceased body was hard to comprehend, and the child still needed to be treated with dignity. The grief was at this moment intensified, and thus the blanket was experienced to become even wetter and even darker. To cling to the good memories gave some comfort and made it seem easier. My second phase of my application is called grief intervention and will be based off this part of the wet blanket theory. Depression is a natural and adaptive response to grief, so during this grief intervention phase, I will have an outpatient therapy program where all family members will each attend 4 therapy sessions alone and 4 together as a family unit to decipher the grief tendencies of each and every family member. The grief intervention phase is set up in this manner due to the difficulties of grief and how each and every person may experience grief differently. Siblings of a lost child experience grief and loss at the death of a younger sibling and have also been termed forgotten mourners. Siblings can also then have the variation, which is the vulnerable child syndrome, where the parents are overprotective of a subsequent child and impacting their grieving processes and their future. Grandparents of the lost child also experience the pain, as one grandmother described her experience with her grieving daughter by saying, "I sit with her and I cry with her. She cries for her daughter and I cry for mine." As we know, men and women tend to have different coping mechanisms, which can make it hard for spouses to be each other's main support. Women have been found to confront their emotions more than men, while men deal with this stressful life event by using more avoidant coping strategies. The grief intervention part of the program acknowledges how both spouses are not only affected by their own grief reactions and means of coping, but also by the way their partner copes too. Not only have both parents lost their child, but the person to whom they would probably turn in stressful situations may be too distressed to provide support, and the differences in coping mechanisms among the two may even create more distress. The emphasis of these multitudes of therapy given is in effort to discover any parental coping conflicts that may arise and address them before it's too late. Following the individual and fit therapy sessions given, from this point, a personalized grief/coping plan will be developed. This is where family members will establish their grief needs, social supports, and mechanisms of coping, and then receive a personalized plan including therapies, outreach programs, cancer support organization involvement, as well as resources to help them throughout the rest of their difficult time. Final portion of the wet blanket theory says, gradually, the blanket dried little by little, but it still felt overwhelming. Sometimes, when emotionally hard memories came forth, it rained grief and pain, and the blanket would once again become more wet, dark, and heavy. With time, the rain did not come as often as before. A way of handling the grief could be to live in the moment since the future felt too uncertain. As years passed, the blanket became drier and life became brighter and less oppressed, but in some ways, it would always be present. The final phase of my application is the postvention phase. This phase directly follows the grief intervention phase as it established a systematic plan to arrange check-ins. The program enrolls each member of the family to individual therapy that will initially be scheduled once a week for 4 months and biweekly for 8 months. After the 8-month period, it'll be once a month for 12 months and then at least twice a year for the next 5 years. Using the keepsake tool in the first phase, families will also reflect on the things they wrote during their postvention. This phase's basic goal is to assure long-lasting wellness, as well as one can be in this situation, for the entire family. The main problem we look at is families and how families cope with the loss of a child. However, the overarching issue is pediatric cancer. The biggest obstacles in curing pediatric cancer are lack of research, lack of public support, lack of awareness, and lack of funds.